Good evening. So I hope I am audible. Okay, so we will start up with the session. Today we are talking about getting to know about bipolar affective disorders. So it's non-pharmacological management. We all would have, in a layman language, we would have known that it comes with an episodic and people change their mood and behavior. Sometimes they're hyper, sometimes they're very low. So in previously in mythology, they used to call that in a full moon day there are changes which happens. So more or less, it is called as a bipolar affective disorder. The name itself suggests it's a bipolar. Okay, so here in this session, we would try to know about what is it, how common is it, what are the causes for it, and is there any brain involvement in this? It's a psychiatric disorders or signs and symptoms. How do we actually recognize and what are all the therapy things which we can implement on the patients? So, see, bipolar in the sense, as you all can see here, there is something called as an euthymic, which you see here, and there is an upper, axis, you can see manic and a depression. When we are talking about the mood, bipolar disorder is nothing but a mood disorders. So where there is a fluctuation in the mood. Fluctuation in the mood is so much so we all have this something like whenever we feel sad and something happens, bad happens to us, we feel sad. Whenever something very kind of nice thing, we feel happy about it. But it is only the context of the time in the period. We cannot remain the sad for the whole period of time or a continuous amount of time, or an happiness is there where there is an elation of the mood for a continuous period of time. It usually does not happen. But what happens in some people is the people who are more prone for a bipolar or having these kind of an issues, there is a pervasive sadness. See, the lower loop which you're seeing is a depressive episode which the patient has. So his mood is continuously with the low mood. And here is a manic episode which he is having, where there is having an uplift of the mood. So what happens here is there is an in and out, there is a fluctuation in their mood continuously. Maybe it's a time frame which I will be discussing even more further. So how common is a bipolar disorder is, see, lifetime prevalence may be around 2.6% to 7.8% in India. This is a very recent survey which is done by National NIMANS studies, which has been conducted in 2020. So here they have told almost, which was about 2.6% to 4%. Now it has increased in the fold of 3 to 4%. There is an increase. So why? Maybe on multiple factorials like in pandemic and multiple adverse life events where a lot of people are facing. All those things might be in one of the factor to it. And again, male and female, it is nothing it has more prone, male are more prone or female are more prone. But you actually have heard like, depression is more common in a female. That we are talking about in what is called as unipolar depression. When we are talking about a bipolar depression, bipolar itself, the diagnosis can be made, or it can be told that the person is a bipolar if he is having an elation of the mood and also depression of the mood. Both has to be present, and then we call it in bipolar. But few clients you might have seen, they have only depressive episode. That we call as a unipolar depression. Okay. If we are coming to genetical predisposition, if the person has one parent who is suffering from a bipolar disorder, is more prone for 30% chances. See, these are the risk factors. It does not mean 100% he is going to be inherited from his family, not at all. But yes, he is more prone. It is something like, you have a diabetic and your children are more prone for a diabetic if the one parent is diabetic 50% and the both parents are more risk factors. So it's similar to that. So if it is both parents, it is almost about 75% of the time, it is more chances that the sibling, their offsprings might have can develop an bipolar disorders. So now coming to the causes for it, is there anything which causes this bipolar, or who are the people who are more kind of risk factors is more? One is, we have segregated here in a multiple things like in biological risk factors. So here the biological risk factors are having a family history and neurodevelopmental factors, and having a temperament like an impulsivity, having more prone for gambling or a drug addiction. So all these things are in temperamentally, like in people who are more having ADHD kind of an they present. So that also can they're more prone for developing a bipolar affective disorders. Then having in psychiatric issues, people who are suffering from an anxiety or depressive symptoms, or lability of mood, or psychosis, or sleep issues. So these are the people who are more prone of developing in bipolar disorders. And coming to the other risk factors, or in life events like in stressful life events, or having an issue with they would have undergone a sexual abuse or a substance misuse, or an people who are already on an antidepressant, they are more prone for developing a bipolar disorder. So you can see here people who have an anxiety or a depressive symptoms, maybe they would have come to you for a therapy, or come to you for a treatment of an having an depressive or an anxiety. Over time, they're more prone for developing a bipolar disorders. For us, it is very important for us to eventually evaluate every now and then. Okay, so this is very, very important as we take up the patients for the sessions, and continuous evaluations is very important uh, for a mental health professionals. Now, coming to whether the bipolar disorders is something is wrong in the brain, is there anything to do with the brain? One thing we have to understand here is, see, it is in any mental health issues, any psychiatric issues for that as a neurobiological base. We feel emotionally upset, our mood is low. That means very much that the serotonin, which is a neurotransmitter in a brain, it has dipped in its level. We are very happy, something reward seeking, we feel very happy, winning a prize, or some pleasurable activity. That means neurochemical in our brain, the dopamine, it's in a higher level. So for every emotions we feel or we pursue, there is some main switch over there, which is called as a brain. Okay. So dorsolateral prefrontal cortex, which is a blue color here, you can see this part of the brain, it is more commonly involved with the motivation and executive functioning. That is, to keep ourselves motivated for an executive functioning, in the sense to plan something, to implement it. Okay, so these are the brain which is involved. So you might have known the people who are addicted to ganja, who are in cannabis addict, substance abuse. They are very amotivated. They do not have that zeal to do things. They're always lethargic. They do not have that kind of an involvement in doing things. For them, when we do an MRI, these are the part of the brain which has an atrophy. In that sense, it shrinks. Okay. In the same way, in the people who are having a bipolar disorder, as I was mentioning, that they have an hyperactivity. That is, they have an increase in their energy. That is why they have an executive functioning. There is an overactivity of this part of the brain, where they make a tall claims, they invest in the wrong investments, they lose a lot of money, they have a lot of ideas, they're very chirpy. So all these things are the things which happens in a dorsolateral prefrontal cortex. Then there is a part of the brain which involves in that much of an, there are part of the brain which is involved in a certain, functioning. See, we in a house, we have a kitchen to cook, a living room to watch TV, or to invite the guests, bedroom to sleep. So like that, the brain is divided into a different compartment, which handles a different emotions and different kind of issues with us, emotions rather. So If there is any problem with the reward, anticipation, decision making, empathy, emotions, so these are the kind of part of the brain which is involved. Then amygdala, hippocampus, there is a learning and memory. These are all the string. So this is the circuit. You can see the arrow mark all around here. So they are all interconnected. Okay, so whenever we have to think executive functioning, we have to know our previous memories, which has been stored there. So based on the previous experiences and the memory, we need to be executive things. So these are all interconnected. So that is why any mental disorders, for that matter, anything we think or our perceptions, our thoughts, our learning, everything is controlled by our brain. And it's a neurotransmitter. It is involvement is there. Okay. So now, if I'm seeing in my clinic, if it's a manic episode, so how do I recognize it? So do they present in a specific symptoms? Can I say, okay, this man is having a hypomanic episode, or this person is having a mania? One mnemonic here is dig fast. Okay, so it's a very easy to remember. So I have used a mnemonic, but as such, when we are doing it scientifically, when we are referring to the books, this are given in a very different way, a kind of a very explanatory and very kind of a technical term is being used here. So for our understanding, let us stick to this thing. One is distractibility, that is a person cannot be sustained in one task or one topic. He will usually have what is called as a flight of ideas. That is, he might be shifting from one topic to another very fast, one ideas to another. So that is easily distractibility is there. Insomnia in the sense need for sleep is not there. He starts thinking that he need not have to sleep. Sleeping is a waste of time. He has so much to do in his life that sleeping is just an utter waste. So that is why we call as decreased need of sleep, which is an insomnia. Coming to grandiosity is making a tall claims that it can be bizarre, it can be non-bizarre. Bizarre in the sense patient might claim, I'm the one who is responsible for the rain, I'm the one who controls the weather, I'm the control, from here I can control the traffic. So these are all the grandiose ideas which are bizarre. So non-bizarre can be, I know Prime Minister, I can I can do whatever the work you give me, I can get it done. But like that, I know a lot of people, I'm very influential. So like this, he has a much of a grandiose. Then as I was mentioning, flight of ideas, shifting from one ideas to another. Activity level, that is the patient is psychomotor is very active. As his brain works faster, even his actions also is much faster. That is, he goes from from one place to another. He cannot sit in one place. He cannot sit calm. Speech is very fast, but yes, you can comprehend. It is more coherent and reliable. But what happens is he shifts from one part to another. Like in schizophrenia, what happens? How do you differentiate? See, whenever there is a psychotic patient who comes, speech is, kind of, you cannot understand what he's talking. He will have some new words he brings up. You cannot understand what he speaks, but yes, it is audible and he speaks well. But in mania, how do you differentiate with the speech is his speech is very clear, it is very comprehensive, and it is understandable. But the thing is, from one topic to another, he keeps shifting, and it is very fast. Thoughtlessness, see that he does not think, there is no appropriateness in what he talks. He sits and you talk, and he can talk in something else. So like this, the topic changes from one to another. If we have to diagnose for mania, clinically, I need to be diagnosing at least for 4 days of minimum. He needs to be doing all these things, irrespective of whether it is induced by medications. Okay, so 1 week or more, then I can make a diagnosis of a manic episode. If we are talking about a depressive episode, Psychosocial is one of the mnemonics which is more commonly used in clinic, but it isn't scientifically, it is a different criteria as such. One is sleep, it is impaired or increased or decreased. Anhedonia, what we call lack of interest. Guilt or worthlessness, I'm not fit to be anything, I'm not worth living. Decreased energy, most of the time it is, patient is very kind of, you can see him head down, thinking too much, he does not want to make an eye contact. All these things are in his appearance. Then concentration, he's unable to concentrate much of whatever he tells, but he's more preoccupied with his depressive cognition. Okay, not much of an receptive. Appetite can be decreased or increased. Psychomotor activity is very low. Suicidal thoughts and plans. If we want to make a diagnosis of a depressive episode, then it has to be more than 2 weeks of pervasive sadness, that is a continuous sadness. If the clients have, then I can say it's a depressive episode. Now, if I want to call the patient to be a bipolar, so how do you make a diagnosis? If I want to say, call the patient of having a bipolar disorder, is patient at some point of his life should have both hypomania and a depressive episode. So I can tell that, for example, if I'm was talking to Mr. A, Mr. A should have, like say 3 months back, you can ask the, attender, bystanders or an informant about his mood changes. They would usually explain in this way that, 2 months back, he was very jovial, making up plans, he shifts his job, kind of he comes up with the startup ideas and all those things. And after a month or so, we saw him, this is how he is, very low, does not interact with anyone. He does not, most of the time he does not sleep, he just cries. And also one or twice he has contemplated, what is me worth living? So these are the things how the usually a client comes, they would have explained about the mood changes. So then we have to understand it is not just about a depressive episode, it is also some point of time he had a manic or an hypomanic episode. So how do we differentiate between a hypomania and a mania? Mania is a full-fledged where he needs an assistant, where he's every day-to-day life is disruptive. Whereas in hypomania, a lot of people, we are like that, we want to do a lot of things, motivated and all this. But what happens in such people is their functioning is not disrupted. They can go to their office, they can still function, but they're in a higher level of mood. So whenever we have a client of a depressive episode, if we are thinking, it is always mandatory for us to ask whether he had any mood changes, which is very hyper or elated mood. With this itself, we can make a kind of a very clear with, yes, the patient has a bipolar disorder. Then our non-pharmacological management of CBT and all those things itself changes. So we can have a better understanding with it. So is it an bipolar disorder is the same entity or only single, or it has subgroups or multiple things? One is bipolar 1. Patient if is having one or more of manic episodes or a mixed episodes of both mania and depression, then we call a bipolar 1. We call a bipolar 2 if one or more of a depressive episodes and also hypomanic, but not manic episodes. Here in bipolar 2, it's the most commonly seen in our population, and also patient would be functioning well. It is not that, the patient does not have an adequate level of an functioning at home. So the other thing is what we call as a cyclothymic disorder, where usually client might come and approach that, there is always a fluctuating in the mood. Either for some time he's very hyper, sometimes he's very low. But you cannot fulfill the criteria for having him to a depressive episode also, and also a hypomanic episode also. So in that kind of a patient's only symptoms are fitting in, then we call as a cyclothymic personality. And unspecified, whether, kind of a rapid alteration in the mood, that is, rapid cycling also, we could call them. What is a differential learning? Often we make mistakes of having an ADHD. Okay, so one is, as I already was mentioning in one of the slides, that, they have an increased in hyper, they cannot sit in one place. they cannot stand in a queue, and they're always agitated if there's something is not done in their way, road rages and all those things. That is why it is being mistaken with an ADHD. Okay, so it usually mimics, the symptoms usually mimics with a bipolar and an ADHD. For us to come into the diagnosis, it is very, very important, because if you're not making a careful diagnosis of a bipolar, if we think only person is having an ADHD, over time, he might get into a manic episode. That means the golden period of us for treating it, we have missed it. So that is very important. And also unipolar depression. Patient for us in a first episode, he might come with an unipolar depression, having a depressive episode, but he might not disclose the symptoms of a manic symptoms. So 1/3 of the patients of depressed patient might end up having a bipolar disorders eventually. Schizophrenia, we might diagnose him of schizophrenia. Like as I was mentioning, patients might have kind of an delusions or hallucination that bizarre hallucinations or bizarre delusions. I am the one responsible for rain. I'm the one responsible for weather here. This is country is I'm the one who is with me. I know a lot of influential people like this. Whenever the patient's making these kind of tall claims, there might be a misdiagnosis of a schizophrenia. Okay, the other thing is borderline personality disorders. Almost about 2/3 of the people who are having a borderline personality disorders might end up having an bipolar. Why? Because of one of the entity often having an emotionally unstable and impulsivity. This is one of the very entity in a bipolar, where I do not have to go in detail with the bipolar borderline personality disorder, where they haven't tended to cut marks, they feel pleasure with the pain, they're very impulsive, they do not think about the consequences. All of this more or less relates to an hypomanic episode. So that is one we have to note down with. So regarding the course, what happens to these who are having these kind of bipolar disorders? If it is late manifestations, or in adulthood, prognosis is good. But if it is in childhood, having in conduct disorders, conduct problems, or having in comorbidity of substance abuse, then we would say that course, it has a poor prognosis to it. And also it is very important because 5 to 10% of them end up having a suicidal death. For us, in our OPD, suicidal assessment for any depressive or hypomanic or manic episode, it is very, very important, and all the careful has to be done. And regarding how do we proceed with these things, one is assessment and diagnosis of bipolar disorders is very, very much needed. One is thorough assessment, which needs to be very structured. It needs to be multimodal and revisited throughout the treatment. So probably when I was doing my CBT and the other courses in NHCA, this is what have been emphasized, having a thorough, structured and multimodal. See, counseling anyone can do, but having a systematic way of it is very, very important. So that is what probably I would want to emphasize on. This is what have been learned through the being enrolled in an NHCA Singapore course. Okay, so one thing is non-pharmacological management is one is evidence-based, CBT, interpersonal therapy, and a family therapy. This is one of the very important for the patients, because see, giving only the medications will not be sufficient to the patient, and also having it to be involved with the CBT and interpersonal therapy and the family therapy is very, very important. I would want to tell you in why it is so. One is whenever the patient has an acute mania, probably whenever this I always see it in my OPD, being a psychiatrist. But whenever there is any counselor or a psychologist, when they're practicing, maybe this has been they have passed this on, a referral has been given when the patient is stabilized. But it is very important as a therapist, any mental health professional, to assess these things. One is assess the risk of harm. ambulance regarding their admissions, inpatient placements, where do they get the consultation with the psychiatrist to assess the sleep deprivation, whether there is any psychotic symptoms or not, because it all depends on what kind of a medications I would want to start for the patient. Now, coming to an CBT for bipolar. So what is that CBT and what would want to do for this bipolar clients? One is a depressive focus phase, right? One is treatment contract phase, because they would be on a long period of treatment for maybe for a lifelong. That complaints for a treatment is also my responsibility. Problem risk phase. See, just for giving a treatment would not be enough. He would have in other life events, other consequences, all these things. So he should be able to identify it and also should be able to solve it and lead the life along with that, managing it. And well-being phase is, kind of putting back into the community where he can earn for himself and lead his life. So this is very, very important if I'm considering CBT for a bipolar disorder. Then psychosocial overview here is, apart from that, see, CBT supported therapies. Yes, I'm giving CBT, interpersonal therapy, and almost and also a family. So how do we come up with it? First is education about the bipolar is very important. Now, I'm telling the patient, see, because most of the psychotic schizophrenia or a bipolar, they do not have an insight. There is an absence of an insight. So where do I start with? Either I should counsel the patient or patient attenders. Now they have come for the CBT asking, no, he's already been on the treatment, but how do I make him not dependent on someone else? Resilient. So resilient, how do I make it? So this is one of the things where educating about the bipolar is very, very important, because even for a drug compliance is an important step. I need to put an insight to him saying, what is this episode? How does each episode presents it? How does he identify the warning signs? Then mood charting. Why is mood charting very important? Because to identify there can be any fluctuation in the mood. Then improvement of treatment adherence, because it is a long term. People are very ready to accept, yes, they have a diabetic and a hypertensive for lifelong, they have to take the medicines. But when it comes to mental health issues, people are very kind of stigmatized, and they usually come and ask, no, now I'm all right, because it is episode, inter episodes is almost functioning and is doing well. So now he wants to stop the medicines. Whether that has to be emphasized, we have to look into it. And discussing the consequences of impulsive behavior. Impulsive behavior is one of the entity for having a manic episode. So how do I control? He loses money, he invests in a wrong investment, all these things as a burden to the patient and also to the family members. So how do I put forth all these things? Sleep hygiene. Sleep hygiene is very, very important, because biological function is one of the things, early signs to predict, yes, the patient can get into a depressive or a manic episodes or a fluctuation in the mood. And suicidal risk factors, because I was mentioning that almost about 15% of the people who end up suiciding. So that one needs to be, we need to be tackling it. And also family, we need to also educate the family members how is that they have to kind of relate to the person who is having so much of a mood swings and impulsivity. It's just not about the patient, it's also about the family members. First is educating about what is a disease, how neurobiologically it is there, to explain to them what are highs and lows. CBT model of mood thoughts and feelings and emotions. This needs to be explained to the patient regarding maintaining their mood charts and explaining them what are the automatic negative thoughts, how it can be dealing with. Then what are the warning signs of the mood if there is a shift in the mood? Like how does he himself identify, yes, I am having a mood issues. Now I am very depressed. I don't enjoy anything. I do not have an interest in anything. Now there is a continuous thoughts about death. Now I have to immediately approach to my therapist that there is the doctor, this is what is happening to me. Am I suffering with a depressive episode? Now what is that? How do I come out with this? Is the patient talking more or staying up late or feeling like he has a special power? So all these things. Now, if I'm dealing with people who are within age group of an adolescent age group, whether there is a scholastic deterioration, there is something he's not studying well, all these things needs to be addressed. So systematic assessment is very important regarding his daily mood changes, sleep pattern, and all those things to be in and out of his every day. A quick assessment needs to be done whenever he comes for the sessions. Okay. And also recognize the problem areas for the session, whether the patient is not willing for the sessions or they are having any constraint about bringing to the patients, or patient is not able to understand, or what are the problem areas, whether he's the only breadwinner of the family, he's not able to work, then what is that we have to do? Can we involve them into a marital therapy, or get the person into and make the strengths of a wife stronger? So what is that problem areas we need to be addressing? And other various techniques, relaxation techniques, or other various techniques which is being taught in an in a mind coach, emotional well-being mind coach in NHCA Singapore. That also has, when I have applied on particular patients about bipolar, I have seen a tremendous results over it. Okay, so coming to treatment adherence challenges is, so make them understand the importance of medicine is very important. Like whenever the patient says, I don't know, I'm all right, I don't want to stop my medicines now. So usually this is the thing which we notice usually. So whenever the patient says that, one thing we should always ask, what was it that when you were not taking the medicines, how are you now when you are taking the medicines? What are all the pros and cons? Few patients might say, yes, I feel very drowsy. It makes me very low. It makes me very drowsy. So apart from that, is there anything good which is happening with the medicines? And if it is drowsy, I think you should visit a psychiatrist where they can optimize your medications and see that you have a less side effects of any sort. So this needs to be our approach. Then identifying social rhythm, that is his biological, social, and occupational. These are the three entities which we need to be emphasizing on. That is in biological, sleep is appetite. Biological, social is an interaction with the people, his daily routine. Occupational, whether what is that he's attending to the job or not. This is very, very important for us to over and over assess for an impulsivity, because what happens is whenever the patient is having an hypomanic or a manic episode, he usually gets into a promiscuous behavior, having a multiple sexual partners, or spending too much of money, or overspending, on arguing or fighting, school or work refusal. So all these things might be an impulsivity which he is noticing. Okay, so practicing slow down techniques like kind of mindfulness, stop, think, and act. These are all the CBT techniques which we can apply on the patients, or working on a relaxation or a problem solving skills, identifying it. So thought impulsivity, how to control the thoughts, and how do he whenever he's having a mood changes, how can he communicate this to the family members? So this is very, very important for us. The rule of two, that is, check with the two family members. See, I want to invest in this, or I have multiple ideas which is coming. Is it a correct thing, or is it a wrong thing? So checking with the two family members is very important for the clients. Then sleep hygiene, work on a regular sleep schedule. We all know this. We have been telling a number of times to almost all clients who come to us having a sleep deprivation, like watching TV or video games and exercise, and bedroom should be only assigned for sleep. Then any stimulation like in coffee or drinking anything like that, or avoid sleeping during the daytime, and journaling and window down routine. So all these things are need to be emphasized. Then very important point is suicide risk factors. We have to assess whether the patient has a family history of a suicide in their mother, father, or any other siblings or anyone. Then alternating behavior. See, dialectic behavior therapy is one of the things which is used in the borderline personality disorders. But we also need to assess, because they're more prone, borderline personality disorders, people are more prone for developing in bipolar disorder. So this tip skills like temperature, intense exercise, whenever they have an acute anxiety, or an acute kind of a mood lift. So these techniques are the one which we need to be teaching to the patient. If at all he's having a suicidal contemplation, then we need to invariably involve the family members. Then explaining to the family members how do they maintain the anger of the family, problem solving skills, and how do they reciprocate with the people who are suffering with the bipolar disorders is very, very important for us. Okay, so what I would say is, see, it is not about the patient. When we are treating with the bipolar disorders, it is just not about the medicines. Medicines will do its work because there is having a neurobiological changes. But what is important for us here to understand is it is involving both of the pharmacological and as well as non-pharmacological involvement in the patient's uplift. Betterment is very, very important. Okay, so I think with this, I would end my session. So any doubts or discussions, I think we would proceed with that. So I would stop the sharing the screen. Okay, so here is a query which they have asked is hypomania to be kind to be treated or not? Should we treat an hypomania or not? See, when we are diagnosing itself hypomania, that means it's a disorder. Maybe it is not of an intensity of a mania, but still patient have a mild disruption in a is this functioning. So that is where it is very, very important for us to treat. Okay, so one is from Dr. Sharish Fatima, where they ask, ma'am, normally also this happens. Sometimes we feel depressed and sometimes very energetic. How is it different from bipolar? See, one entity is, if we are diagnosing of an hypomania, there is a mnemonic which is there, big fast, where is a distractibility, and I'm not able to sustain. If this set of mood is there pervasively, continuously, and it is disrupting our normal life, elation of mood, kind of a blissful, what we call. So that is where it needs to be diagnosed. Normally, we feel sad when there is something bad happens to us, happy if something good happens to us. Yes, it is a normal emotion. But if it is disrupting my normal routine, I'm not able to concentrate with my normal routine, it is a problem, then I think it needs to be diagnosed. If a person says yes immediately and after sometimes for opposite days, their decision as no, after few more times days, there could be say, maybe, is this a bipolar? No, this only entity cannot be a bipolar. It is not about yes or no. It's just about the mood disorder. Yes or no is one of the clinical features which we call as an ambivalent. Cannot make decisions. Okay. So cannot make decisions. You give a glass of water, he will be very apprehensive whether to take it or not. Okay, so that is one of the things where you have an ambivalent. What if the patient is not willing for a treatment? I think this is asked by Urvashi. So Urvashi, if the patient is not willing for a treatment, see, patient does not have an insight. So a lot of patients lose a lot of money, financial constraints are there, they make a lot of loans, all these things are there. It is not only for the patient, it is also a burden for a family. I think there is something called as an, according to Mental Health Care Act 2017, there is something called as an supportive assistant, supportive treatment, where even if the patient is not willing, can be taken by the doctor, can be treated. Okay, once the patient is having that kind of an insight, and then we can work on the further down, but it needs treated. Does it, Karen is asking, does it require lifelong treatment, or are these cases where a person has been cured of it? It's an episodic illness. A person can have 6 months of a depressive episode, 1 month of a manic episode. For me, a main agenda for me or a goal for me to not for him not to have further episodes. Because inter episodes, he's normal. You cannot say he's a bipolar. You can never make. If you cannot say a person is having a diabetes, looking at him, it's the same way. You cannot say the person is having a bipolar. If you ask me whether having a bipolar is a better or schizophrenic, I would always say bipolar is much better, because inter episodes, you're absolutely all right. Only my main goal would be not for him to have further episodes. And can it be cured of it? It can be controlled. So, okay, so there is one Triveni who is asking, acute depression at a given time, for example, who feels absolutely depressed in the evening to such an extent which does not want to go home, is this also a sign of severe bipolar disorders? Depression has a diurnal variation. Okay, so most of the time patient is either early morning very depressed, as the day goes on they're okay, and as evening sets in they're very depressed. If this thing persists for a longer period of time, we can call it as a more than 2 weeks, we can call it, yes, the patient is having a depressive episode, but only we can call can be a unipolar depression if the person has only depressive episode. If the person has more or less, kind of an uplift of the mood, upper limits of the mood and the lower limits of the mood, then we can call it's a bipolar. Okay, so having only depressive mood cannot be diagnosed to be a bipolar. And okay, so Deepa is asking me, example will help me connect well. Give examples related to bipolar disorders. Okay, so examples in the sense what I could understand from this is, one is elevated mood. For a few days, patients might say, I'm very happy. So when you ask him, आपको आपका मन कैसा लगता है? He says he's very happy. He cooks food for people. He goes distributes to the people. I'm not telling having a philanthropic entity is a bad, but at the same time, after such period of time, he's very low, he's very depressed. In spite of his family struggling, he's doing all these things. Having an impairment with his biological function, with the sleep, appetite, all these things. Apart from that, he's claiming that he's having a superpower to do all these things. That is where, Deepa, I would say he's having a hypomanic or manic episode. Having to said depressive episode, not interested in anything. He says, my life is not worth, I want to die. Why should I be living? When this is continuously there, then I would say having a bipolar disorders. Okay. So one of the Dr. Avanti has one question. So is the family at any danger due to the violent episodes by bipolar? See, most of the time it is an impulsivity which can be provoked or which can be unprovoked. At initial stages of illness, usually they are confused. They do not know how to react. They do not know what is happening in them. That is why awareness about the mental health is very, very important. People are usually seen whenever they are throwing away things, damaging the articles at the home, breaking away wash basin or kind of washing machine, throwing away things. All these things is when the patient is brought. When you ask them retrospectively, from when on was the person not all right, they would say, no, from past 2 to 3 months he has been very upset. He's kind of very changes in his normal behavior. They do not bring to the doctor. That is why we can say there can be violent episodes, but more or less it is, until and unless it is, we cannot say the crime which is related to a bipolar having to injured someone usually does not happen. Shilpa is asking how we can know if it's bipolar or a depression. Bipolar has two entities having a depression and hypomania, whereas in depression, unipolar we call, which has only depressive episode. Patient from past 10 years been continuously having a depressive episode. Never in his life has a hypomanic episode or an elevated mood. Then we call it's a unipolar depression. Okay. Then will the family also need counseling to deal with the clients who has a bipolar? Yes, of course. See, once you might have seen in any of the illness, like like a child who comes to us with an learning disability or an emotional issues, or a person who is having depressive or an anxiety, where the person feels that he has so much of a problem where the other person cannot understand, where the spouse cannot understand. So for us, it is very important. Doing a family counseling or a family therapy is very, very important, because we need to make them understand. See, this is not just some usually in our country it is known as Bhoot ka Saya, some full moon, or in when there is an no moon day, he is having fluctuation of the moon, having talisman, go to a church, go to a dargah, go to a temple, this will be all right. See, because it is an episodic, it subsides, but he might end up having in multiple episodes. So that is why family educating them is very, very important. Okay, so Preeti is asking, I have a client whose mom passed away and suddenly she plans to get married. I saw a depressive episode and then suddenly manic episodes. What do you do? Okay, so in these kind of things, see, as was mentioning, there is no kind of insight in the patient. At that point of time, we need to actually, who is a near family member? Do they have any near family member? So keep them into a confidence, explain to them. See, usually patients ask whether inter-episode they can get married. What I would suggest is, get married in the sense, marriage is a very big commitment. So whether the patient is prepared, whether the other person party knows about this, explaining to them, telling them, yes, there is a lifelong treatment is necessary and also therapy is necessary. So having to explain them, taking into confidence is very, very important for us. Okay, so I hope I have answered it, Preeti. Okay, so Bharti is asking, okay, so Ranjana is asking, as it can be genetically carried, is there anything family can do for a better well-being? Yes, of course. Having a conducive environment. If the father is having a bipolar, keeping him into a drug compliance is very important. So so that he does not have an impulsivity, does not have an adverse effect on the children. Having a good environment for the children is very, very important. Okay, so with this, see, it is only a risk factor. It does not has a mandatory that mother has a bipolar, children have to have, or a father has a bipolar, son has to have. It's nothing like that. It's only genetic predisposition. Okay, so if the person is very irritated early morning and settles as the day goes on, is it bipolar? No, I would not say it is a bipolar. Maybe an undergoing cumulative stress which is having makes him do this, kind of mood changes. We need to again put him into a mood chart, explain him what is happening, why is he having these kind of a mood changes or mood swings day to day on. Okay, so this is very important for us to figure out. Any changes in the mood, we cannot jump on to having a kind of telling him, yes, you might have a bipolar disorders. Okay, so Neha is asking, I want to ask that if a person who is usually quiet in nature suddenly becomes very talkative, laughs unusually, is this a sign of emotional turbulence? It can be. Okay, so one thing is we need to always evaluate whether he is on any other medications, because most of the time steroids also causes an uplift of the mood, whether he is having any other issues. diabetic, hypertensive, or any steroid for any other medications he is taking. We need to evaluate that. And we need to say, was there any predisposing factors to it? How did all this happen? Laughs, talkative, whether it is going to a psychotic episode, whether he is talking to himself, how many days he is in. See, one thing, a thumb of rule is we need to always consider there are three things whenever we are evaluating patients. One is biological, social, and occupational. These are the three main thumb rule we need to always ask the patient whether what is that we need to be doing. Okay, so okay, so I want to ask if a person is under the influence of drug is being violent and aggressive, and even so it is a bipolar. No, it is not a bipolar. Under intoxication, most of the people who are having an alcoholic, they behave under the influence of alcohol. If the patient is alcohol itself is in almost about 2/3 of the patient who are dependent on alcohol end up having an either schizophrenia or bipolar disorders eventually. Okay, so we need to evaluate whether independent episodes of bipolar or depression is there. That means this alcohol is the one thing which is hijacking his mind. That is, it is replacing his mind. So we need to evaluate that thing. So I would not say a bipolar that needs a need further evaluation for the patient. So okay, so then should we take some medications or visit any psychiatrist? Yes, of course. Okay, so ma'am, without having any help from the family members, office colleagues, from where the person for mental disturbance has triggered off, medicine along with counseling is enough to cure the problems. Is it very difficult to cure under such an hostile situations? See, I will tell you the scenario, the ratio of having a mental health professional to in our country, it's very low. Okay, so there are few hundreds for in 138 crore population. Of course, it's very kind of the treatment gap we can say is almost 85%. So in our vicinity, in our reach, whatever we can do, I think we need to be doing. But yes, if you feel yes the person needs a treatment, it has to be. Okay, so yes, of course. So as Dr. Mittal is mentioning, a technique for an immediate relief in stress. So I was also telling you, see, it has to be a thorough evaluation, which has to be very structured, or multimodal. See, I as a psychiatrist had not learned any psychological management to the patient. But when I started practicing, then I realized it is not just about the medicines. It is about the family, and also psychological interventions is very much needed. And also reading a book here and there, I can get the points, but is it a structured way of doing it? So that helps me a lot in the when I did my emotional wellness coaching under Dr. Mittal, who is an amazing trainer, I should tell you. And it has, these techniques has helped me a lot in this the program in managing most of the patients. I should say that. Okay, so and even now, if I have any doubts and difficulties in managing the patient, I think I would just ring up Dr. Mittal any point of the time and to clarify things, or how to go about with this non-pharmacological management, or how to get along with that. So there are a lot of mentors who is there who kind of it's kind of an treatment, cumulative treatment which is given here. Okay, Ranjana is asking, can a mother who started going through a phase of elevated mood or depression can be considered? No, I think a new mother, it's a postpartum period. So postpartum psychosis is one of the thing which is an thing. Okay, so okay. A person I known, Manisha is asking, who was very calm initially and since last 2 years has started blaming everyone around and angry on everyone for her failures. And what can we say for them is he under depression. Yes, any kind of a psychological distress can lead to an issues, but we cannot brand him to an having in depressive as in bipolar disorder. We all can go through a lot of issues in our life, but the thing is we need to know, identify it and get the help as much as possible fast. Reacts in a negative way, who told to visit a psychiatrist, how to handle it? See, there is a lot of stigma to us. Okay, so Pooja, there is a lot of stigma. People do not want to come to a psychiatrist or a psychologist, visit a psychologist, do not want a counseling and all those things. But we need to emphasize on what is that they want. Has their quality of life come down? How were they before all these things? How are they now? Do they want to be better? Give a chance to them. Ask them what is that they want. Okay, with this manner, we will be able to, kind of emphasize on what is that can be done. Okay, so there are a lot of messages which has been coming. I think I might be missing some few of it. Okay, so I think it's a 7 p.m. So see, one thing, what I would want to tell here is, if any doubts is there, okay, you can always get back to Dr. Mittal. He's the right person who will be, who can, tell you how it can be approached or what is it regarding the course or all those things. So he will be the one who will be, kind of a mentor maybe. We can call. So because I have learned a lot of things here. So, and I have been as a student, now I have come up to an what we call as in taking a sessions and interacting with you guys. So I would want to thank Dr. Mittal for giving me such a big opportunity to be on this platform with NHCA Singapore. I would also thank all the participants for their such an interactive thing. Quite a lot of questions. I think I have missed many of it. Okay, so anything you would want to ask, you can always ring back to or contact back to Dr. Mittal. So I want to end my sessions with this note.
Thank you, Dr. Pavna.
Thank you so much.
Everyone had a lot of questions and probably some of them relatives or some of the question mark diagnosis bipolar disorders. Today it was resolved very well. We will have more session on the similar topic. We will also have sessions by Dr. Pavna again more on other topics as well as this topic continued. And being a psychiatrist, having done fellowship, psychology counseling, marriage counseling, CBT, and emotional wellness coach from NHCA, so she knows a lot of things and she adds value to the learning of everyone. So all of you will enjoy her sessions. Thank you, Dr. Pavna. Thank you so much.
Thank you, sir. Thank you so much.